Well, I'm Greg Olick Sr. from Med-Acoustics, and this particular session is on tympanometry. We're going to talk about some existing functions of tympanometers and also some existing middle ear analyzers, and even about a new middle ear analyzer which is about to be introduced on the market in the United States. These are examples of tympanometers. And some of them are relatively new, and some of them have been around for a while. Some of them have been updated to meet today's standards. This is the GSI 39 Grason-Stadler product, and that's available either as a conventional tympanometer with or without reflex threshold testing or reflex screening, and it's also available with an audiometer built in, just a pure tone audiometer. You can print out tympanograms, acoustic reflex thresholds, as well as audiograms. And it's available also with an option for high-frequency tympanometry. And I'll talk about high-frequency tympanometry in a minute. This is the Mako equivalent of that. It's an MA27, and it has similar functions and options. There are some handheld units. This is an Interacoustics MPT-10, which is basically a tympanometry screener with a charging stand and a printer. These have built-in printers as well, plus computer interfaces, so that you can create PDF reports that are compatible with electronic medical records. And then Welsh Allyn even has a nice little handheld unit, tympanometry only, with a charging stand and a printer as well. So these are typical tympanometers, basically used for screening, but some of them have features beyond screening, like the Grason-Stadler product and the Mako product, features like automated acoustic reflex threshold, and they even both offer contralateral as well as ipsilateral reflex, acoustic reflex thresholds. So you find these everywhere, from school systems to private practicing audiologists, pediatricians, general practices, and ear, nose, and throat practices. A step above these tympanometers are middle ear analyzers. And here are four that are very popular. This is the Grason-Stadler Timstar, and the Timstar comes in two versions. The version 1 does all of the functions that we're going to be talking about in this session. Version 2 does some extra functions, and I'll talk about those as well. This is the Interacoustics AT235. It says new because it has been redesigned and it has a new case. And even though the model number has been around for a decade or more, this new update of it has only been out for the last couple of years. And instead of just doing tympanometry and automated reflex, these systems do more. This is the Interacoustics Titan. It falls in the category of middle ear analyzer. And this is the new Timstar Pro. It will be replacing the original Timstar, and the original Timstar has been discontinued. The Timstar Pro is about to be released very, very soon. And so we'll talk about the functions that make middle ear analyzers different than tympanometers. They have additional features. This is the Timstar Pro, a little bit of a better view of it. When this was designed, we told engineering that there are two things that are very, very necessary. Speed is very important because many times these things are used on a pediatric population, and speed is of the essence. Another thing that's important is noise immunity, right? The patient might not be 100% cooperative, and the ability to use it remotely, control it from the actual patient's side instead of having to reach over to the instrument. It even has a touch screen on it too. And it's completely compatible with electronic medical records. So we'll talk about the features of these types of units, middle ear analyzers. Okay, so tympanometry, of course, is still a test used to detect problems with the middle ear. And that works with this method. This is the method that's been used from the beginning. I've been around long enough that I remember the first commercial equipment that did tympanometry. And so we have an air pump that can create both positive and negative pressure, and we have the ability to actually pressurize the outer ear canal when we make a seal and manipulate the eardrum back and forth. So that's why we have a pressure system, both positive and negative pressure. And we also have a little speaker in the probe that generates a 226 hertz tone. And we, on some of the equipment, we can change that to a 1,000 hertz tone, and I'll tell you why you might want to do that. We also have a microphone in the probe that picks up the reflection from the eardrum. And of course, when the eardrum is pushed backward or pulled forward with the pressure, there is less of that probe tone less of it is able to be absorbed by the eardrum, so that the tympanogram graph is low. When you have equal pressure on each side of the eardrum, this is the eardrum, when you have equal pressure in the ear canal and in the middle ear, then you have maximum absorption, and we're going to compare that with maximum compliance. So here's a tympanogram. Most of the listeners, viewers, will be used to this type of thing. You see, we started out at positive pressure, 200 decapascals. At that point, we pushed the eardrum with positive pressure all the way in and clamped it, so the absorption is low. And then we've gradually released that pressure until the pressure is equal in the ear canal and the middle ear. Now, ideally, that would be at 0. And at that point, there is maximum absorption. And so you have the peak of the tympanogram. And then as we apply negative pressure, right, we're pulling the eardrum out now, the absorption goes back down. And we relate absorption with compliance, okay? The amount of movement that the eardrum has. This is a normal tympanogram, or we would call a type A tympanogram. And you may remember that there is a type A tympanogram, completely normal. There is also an A sub S, S for shallow. This is when the tympanogram is lower than normal, has less movement than a normal eardrum. And there can also be an A sub S, S being deep, deeper. Here is an example of a patient who has ossicular discontinuity. One of the little ossicular bones, one of the bones in the ossicular chain is actually broken. So it's kind of flopping in the breeze. So as we put positive pressure in and then release the pressure, this is so high because the eardrum is floppy and it's off the scale and then back down again. A sub S. So A is normal. This is A sub D. A is normal. A sub S is insufficient or less than normal movement of the eardrum. A sub D is more than normal movement of the eardrum. And then you have a flat tympanogram. Sometimes it arcs like this, but essentially flat tympanogram. That means that there is fluid in the middle ear, and so you have much less movement than normal. And then you even have a type C. Here you have normal movement as far as the height or the compliance value. However, the peak is out here in the negative area, which shows that the Eustachian tube isn't working right to vent the ear and equalize the pressure in the ear canal, which would be ambient pressure, and the pressure in the middle ear. And of course, you have pathologies that are associated with each one of these that are not normal. The type B is generally otitis media, an infection of the middle ear causing fluid in the middle ear. C is a Eustachian tube that's not working. It could eventually lead into a type B tympanogram. And Of course, you have a type A that is normal, and A sub S might be otosclerosis, right? A stiffening of the ossicular chain, or you could have a ossicular discontinuity by an A sub D. Okay? It's very good to know these different groupings. Another thing that's important about the tympanogram is the volume measurement, the ear canal volume measurement. If you had a flat tympanogram like this and a very high volume rating, you would suspect that there is a perforation, a hole in the eardrum. Maybe it's a myringotomy tube that is not occluded, that's working properly. So you'd expect a higher than normal. If this was a pediatric patient where we expect a normal ear canal volume of less than 1 cc and we get 2 cc's, well, we're probably measuring the volume of the ear canal and the volume of the middle ear, both indicating the flat tympanogram, indicating that there is a perforation or a patent tube in place. Okay? If we get a flat tympanogram and a very, very low, much lower than normal reading, that might mean that there is a wax occlusion and we're not able to move the eardrum because of that, and that would also give us a low ear canal volume reading. If we have a normal ear canal volume reading and a flat or almost flat tympanogram, then we know there is a middle ear effusion. There's something causing the eardrum, preventing the eardrum from moving properly, probably fluid in the middle ear cavity. Right? So I hope that's helpful, but here's the other functions. That was kind of a review of basic tympanometry. But functions that we'll find in these newer instruments would be something like high-frequency tympanometry, and I'll talk about that on the next slide. Another thing would be acoustic reflex threshold. On the tympanometers, the automated screeners, if you decide to do reflex threshold, it is automated. It determines it automatically on an abbreviated scale. On the middle ear analyzers, you can do it that way on all of them, or you can do it manually, where you can adjust the stimulus to whatever frequency you want, and you can adjust the intensity to whatever intensity you want, and then apply the stimulus and see the deflection on the graph, and you can find the threshold positively and accurately, and you can repeat it and be sure of it more accurately than you could if it was just an automated screener. Reflux decay is another thing that we'll talk about that's on middle ear analyzers and not on tympanometers. Also, Eustachian tube function, and the Eustachian tube function is of two types. Eustachian tube function to test the efficiency of the Eustachian tube when you have intact eardrums, and another function to test the efficiency of the Eustachian tube function when you actually have a perforated eardrum. Okay? Some other functions that you will find available on these middle ear analyzers, some of them is reflex latency. We'll talk about that. And high-frequency tympanometry. That would be used on newborn infants. Reflex latency is how long does it take from the time that the stimulus is applied until the stapedial reflex contracts, and we can actually measure a reflex movement. And if you have something like an acoustic neuroma, then of course, just like the wave 5 would be delayed on the ABR, the acoustic reflex contraction is delayed as well beyond normal. So that might be useful to some patients. Whoops, sorry. On high-frequency tympanometry, instead of using the normal 226 hertz probe tone, which is standard worldwide, we actually increase the probe tone to 1,000 hertz. And we call that high frequency only because it's high frequency relative to 226. It's not really a high frequency. But we use that on patients from birth to about 4 months old. You can go to maybe 5 months even. Some even go to 6. But beyond that, it's not necessary. And what it does for you when you do that is it increases the sensitivity of the test. By sensitivity, I mean the ability to actually identify middle ear pathologies like we just mentioned. It has been found that the ear canal in infants, newborn infants, is so compliant, the ear canal itself, that at the standard 226 hertz, in studies, every single baby had a normal type A tympanogram, whether they had middle ear disease or not. Those are false negatives. And the reason for it was the compliance of the ear canal itself. Well, they found out that luckily, if they just changed some of the measurement criteria, including the probe tone frequency, because of the shorter wavelength, they were able to detect abnormal tympanograms efficiently and increase the sensitivity on that patient group, just that patient group, by adding this feature. Okay. The tympanograms look a little bit different. On an adult, when you use 1,000 hertz probe tone, you usually get a little bit of a W shape. You see this little notch in there? That's very typical. That's because 1,000 hertz is close to the resonant frequency of the adult middle ear. Okay? On infants, if you have a normal type A tympanogram, it looks normal. And you will see a flat B tympanogram or a C tympanogram or any of the other ones. Right? You will actually find the pathology that you would miss if you didn't have this feature. So let's talk about the acoustic reflex. On middle ear analyzers, naturally, you can do this ipsilaterally. That's the reflex stimulus is in the same ear as the probe is, or contralaterally. The stimulus is in the other ear. By having ipsi and contra, you have a little bit more diagnostic capabilities than if you only had ipsilateral. And so the ability to find a reflex threshold manually, not just in a super automated fashion, when you are able to manipulate it down to a 5 dB increments and do it manually, you can determine a more precise threshold, maybe do more frequencies than you would be able to do in an automated system. And it would be something like this. Here we were doing an ipsilateral. That I there indicates ipsilateral stimulus at 1,000 hertz, and we applied it at 80 dB, and there was insufficient movement to call that a threshold. There was a change of compliance due to the contraction of stapedial reflex muscle, pulling back the ossicular chain and therefore pulling back on making the eardrum a little bit stiffer. And I don't use 0.02. Some people do, and a lot of the literature does, but that is just on the cusp. I like to say over 0.02, like 0.03 and more. All right, so at 80 dB, there was insufficient for me to hang my hat on a reflex there, right? A change in compliance. So we went to 85, and there was a clear change in compliance. This time it was 0.03. Went up higher to 90 dB, and we got a change in compliance also, very clear onset of the change, and then here is the offset of it. And the amplitude of the change was 0.04, so that's growth of reflex. 0.02, 0.03, 0.04 as we increase the intensity of the stimulus. Very good. All right, it went to 2,000 on the same ear, ipsilaterally, 80 dB HL, only 0.01 compliance change. Went to 85, still nothing, 0.01. Went to 90 and 0.05, very clear reflex. So this is the threshold, 90, and I would call 85 the threshold at 1,000, with 90 as the threshold is 2,000. And we can do that at any frequency on a middle ear analyzer. We can do it ipsilaterally or contralaterally. Here's reflex decay, next to the last slide. In a normal ear, if you apply the reflex stimulus at a super threshold level, you've already determined the reflex threshold, and you apply stimulus at a super threshold level, 10, 15 dB over the threshold, then you should be able to apply the stimulus, see the change in compliance as a result of the stiffening of the eardrum by the stapedial reflex muscle, and then hold that for a period of 10 seconds and then release it, and see no decay in the reflex. Okay? So this would be normal. And notice this is done ipsilaterally at 500. It can be done contralaterally, and most often is anyway, and usually done at 500 hertz. All right, so here's a case where there is reflex decay. This would be what it looks like. So here you have applied the stimulus and you have a reflex change, but as the stimulus continues on, we're holding the stimulus on for 10 seconds. This indicates 5 seconds here and 10 seconds here. And as we hold the stimulus on, though, the reflex, all right, that's this muscle, the stapedial reflex muscle, it loosens and there's a decay. And if you have 50% or more decay in 5 seconds or less, which we did here, then that is an abnormal finding and is consistent with a retrocochlea pathology like an acoustic neuroma. Okay? One more thing, this is the last slide, and that is Eustachian tube function. Middle ear analyzers, especially like the new Timstar Pro, they all have Eustachian tube function. Eustachian tube function is a very good way to determine how effective the Eustachian tube is at equalizing the pressure between the outside world and the middle ear. And you can do it with intact eardrum or a perforated eardrum. On an intact eardrum, a lot of times what I do is try to do a Toynbee. You know, I try to get the patient to blow, hold their nose, and pressurize their ear. This is adult patients, of course. It's not going to work on pediatrics. And so they're actually blowing positive pressure into their middle ear. And you get a positive tympanogram, right? Maybe one even more positive. And then if you have them drink some water after that, the pressure will go back. It'll be more negative. And you'll see a separation between the two. And when you do have a separation between the two peaks, they pass. If they're superimposed, and you try this several times, and they're superimposed, well, the Eustachian tube isn't working. Now, if you have a perforation or a patent tube, it acts differently. When you select that function, you simply make a seal in the ear with the probe tip, and then the system pressurizes the ear canal. Now remember, you already know there's a perforated eardrum or a patent Eustachian tube. You already know that. You don't find it out with this test. You know that from your tympanometry testing. So you're pressurizing the outer ear canal, and because there's a hole in the eardrum, you're pressurizing the middle ear at the same time. And you expect that pressure to eventually push the Eustachian tube open. And when it does, it'll drop down like this. Okay? If we kept on going, it might drop down a couple of times. You've got to make sure you don't have a false negative here where it simply leaked out, and that's why it looked like the Eustachian tube opened. You have to have a good positive seal that maintains. But if you do, you can actually push the Eustachian tube open and the pressure will drop. And when you see it drop, here the patient might have been drinking water and taking a couple of gulps and was able to get it to drop several times. I say if it drops once, you've pushed the Eustachian tube open, and if you can do that at least by the time the pressure gets to 400 decapascals, then you have a good Eustachian tube. So these are the common functions of a clinical middle ear analyzer, like the new Timstar Pro. Other things, like I mentioned before, like reflex latency, that can be available on this type of unit, and even multi-frequency tympanometry. In other words, doing tympanograms not just at 226 hertz or even 1000 hertz, but what if you did it at all frequencies in between, maybe in 1/3 octaves or something like that, in between, say, 200 hertz and 2000 hertz, and you found the resonant point of the middle ear. That can help you determine and pin down exactly what is causing the pathology better than a tympanogram at a single frequency. But that's the subject of another session altogether. So I hope that's given you a good idea of the basic functions that are available on these types of instruments and the functions that will be available on the Timstar Pro when it is released shortly. As I said, when this was designed, what we care about most is speed, noise immunity, and quick start of the of the tympanogram. In other words, being able to get a seal under less than ideal conditions and quickly start and run the tympanogram and not be affected by noise. Being able to quickly and easily get the 2 tympanograms and either print it or send it to electronic medical records. So that's the end of this presentation, and I hope it's been helpful to you, and I hope you take a look at the new Timstar Pro when it's released shortly. Thank you.